Hi class, welcome again to another session on rehabilitation engineering. So we have discussed foot orthosis in the last video. So moving on, let us discuss ankle foot orthosis today. So AFOs are boots to which the ankle joint is fixated through the use of stirrups. Right? Stirrups are like straps and other supports. It's mechanical upright supports. So there are metal uprights that are ascending up to the calf muscle. So till the calf muscle you have mechanical uprights. So this ensures that the ankle is totally supported during the gait process. So the following are the parts of an AFO. So you have the proximal calf band with leather straps. So in order to tie the AFO to your shin. Then you have the medial and lateral bars articulating with the medial and lateral ankle joints that help and control the plantar and dorsiflexion. So dorsiflexion is the flexion of the knee, and plantar flexion is the flexion of the ankle, and plantar flexion is the extension of the ankle. Right? If you're standing on your toe, then that is plantar flexion. So if you are like trying to stand on your heel, then that is dorsiflexion. Right? So then you have the stirrups that anchor the uprights to the shoe, and other modification to the shoe such as the medial and the lateral support, which can be prescribed for the AFO concomitantly. Right? So if the ankle is very unstable, then you have supports from all the four sides of the you have supports on all four sides of the leg to ensure that the ankle is nicely encapsulated and the patient does not end up twisting their ankle or falling while walking. So this is a typical diagram of an AFO. So you have the foot orthosis here. Let's take a point right so that you know exactly where I'm pointing. So yes, so you have the foot part, you have the foot orthosis here, and then you have the lateral bar and the medial bar and the calf band here, right? And then you have the stirrups here which support the facilitation of the which support the fixation of the bars, right? And then you question like how on earth would the patient be able to put their foot inside this AFO. So they usually there are straps available at the calf band, so that you can take it out. It's like belt, you have buckle or velcro straps. So it's like a belt, so you can open it. So this section is open, and then you have to put your foot in through the mouth or the what was it called, the throat of the boot, and then you have to tie the laces and then fixate the AFOs inside here. So that is how it is worn. So there are 5 types of ankle joint fit to the AFO that are prescribed according to the strength of muscle controlling the ankle. So you have the free ankle one. So this is prescribed for people with normal ankle power. So this free ankle actually, if your ankle is strong enough, but because of some neurological conditions you have issues with walking, then you are prescribed the free ankle or AFOs. Then you have the limited ankle joint. So when the muscle controlling the AFO are frail and they have absolutely no power, then the AFO takes complete control over the stability of the ankle. And then you have the 90-degree foot drop stop. So this is when the ankle joint allows dorsiflexion but stops short at neutral position. So it can be at 90 degrees and it can dorsiflex. It does not allow plantar flex. So if you want to stand on your heels, this orthosis is not going to allow you to do so. Then you have the reverse ankle joint. So this allows plantar flexion but not dorsiflexion. So you can stand on your heels if you use this reverse 90-degree ankle joint AFOs, but you cannot stand on your heel. It will not allow dorsiflexion. It will either allow 90 degrees or it will allow plantar flexion. Right? And then you have the fixed ankle joint. So sometimes the foot needs to be protected and weight has to be taken off from injured portions such as fracture of the calcaneus bone. And then when it is combined, so these orthoses, they make sure that they take weight off the foot. So it's not very commonly used, but sometimes in some certain conditions such AFOs need to be used. So what are the indications? So AFOs are prescribed generally when there is a weakness in the muscle, and the subtalar joints are weak. So this is for preventing and correction of deformities of the ankle and the foot. Then dorsiflexion assistance, wherever there is dorsiflexion assistance required, then AFOs are prescribed, such as to prevent the contracture of Achilles tendon and to assist in heel strike. So then we have the polypropylene solid AFOs that are prescribed to provide stability and reduce deviations in the swing and the stance space to make sure that you walk properly. And then we have the AFOs that are for children with cerebral palsy, and this is to stabilize their foot while heel strike and flat foot base. So they have CP children have a very unique gait. So they have issues with heel strike and foot flat. So these AFOs actually support that. Again, they are made up of polypropylene orthosis. They are made up of polypropylene, and they have the shoe insert which prevents plantar flexion and dragging of the toe during the swing phase. And then you also have AFOs that are prescribed to reduce weight bearing in the ankle joint in conditions such as fracture of calcaneus or instability in the ankle. I hope you had a very fruitful session learning about AFOs with me. We shall move on and learn about KA AFOs and HK AFOs in the subsequent videos. I hope you take care till then.